So basically, I'm just going to touch on just a basic introduction first, and then we'll just discuss the effects of liver impairment on drug metabolism, and of course, the principles we use in deciding the dosage of a drug, or when we are using a drug in a patient with liver impairment or liver cirrhosis. And also, I'm going to then talk about drug-induced liver injury just briefly, and then about drug-induced liver injury in liver cirrhosis, why it is important, and what the specific things we need to worry about are. And then finally, I'm just going to touch on some specific drug classes and some specific drugs with relation to patients with liver cirrhosis or liver impairment. But first of all, let me just say that this is not in no way going to be a comprehensive lecture, and that I'm going to try to cover the broad areas as much as possible. So the first question is, why do we need to know about prescribing in liver disease? So the theoretical explanation is that, of course, we see patients with cirrhosis and they frequently need medications for complications of cirrhosis or for the disease-related complications of cirrhosis, as well as for non-liver related comorbidities. So we always need to know what drugs to start and in what patients, and whether it's safe to use a certain drug or not. Now, this topic is going to be more and more relevant to us in the future, because we are now in front of an impending storm. Like, we are seeing a storm in the distance. I think a lot of you if you are doing general practice, or if you're seeing patients, you might have noticed that there are a lot of patients now being diagnosed with liver cirrhosis as an incidental finding. I mean, they don't present with any features of liver decompensation, but they go to have an ultrasound scan, or they go to have a blood test for something, and then consequently they are found to have changes of liver cirrhosis in the liver, right? And we are sort of sometimes we are sort of at a loss as to what to do about it. So more and more patients in the future will come to you with an incidental finding of liver cirrhosis, which may become as common as diabetes and hypertension in our patients in the future, right? So why is that? Of course, you know the obvious answer, that it is estimated that about 25% of the adult population in the world has non-alcoholic fatty liver disease. So this survey was, this analysis was mainly in North America and European patients, but still 25% of the adult population in the world is is uh, postulated, or considered to have non-alcoholic fatty liver disease. Why is that important? Like, so this article in the New England Journal of Medicine in 2017, they DL and Day, they sort of gave a sort of a bleak outline about the future, or the natural history of patients with cirrhosis. So the prevalence of United States of NASH, or non-alcoholic fatty liver, in the United States was, it was found to be to about 25%, and they postulated that about 25% of those patients will go into NASH. The patients with NAFL, about 25%, that is about 5 to 6% of adults, and out of that population with NASH, about 25% will go into cirrhosis. So that is, they are hypothesizing that about 1 to 2% of adults in the United States will have cirrhosis or cirrhosis related complications, especially hepatocellular carcinoma, in the future. So this is a huge patient load, and this is a very sort of a bleak premonition, and that is something that sort of alarmed the scientific community. And of course, now the next important question is, what about us? What about us here in Sri Lanka, whether we are better than them or whether we are worse than them? So how common is NAFLD in Sri Lanka? So in the Ragama Health study, in about nearly 3,000 urban adults aged between 35 to 65 years, about 32% were found to have evidence of fatty liver on ultrasonography, right? And in a 7-year follow-up, nearly 66% of the followed up patients have ended up getting fatty liver. So it is sort of, I think it's safe to assume that we are at least as bad as the United States, if not worse, right? I think I suspect that we are worse with regards to the prevalence of NAFLD, which means that there will be a very significant amount of patients, a significant burden of patients with cirrhosis in amongst this non-alcoholic steatosis or non-alcoholic fatty liver community in the future. Just remember that it takes about 10 to 15 years at least for significant fibrosis and cirrhosis to develop in patients with a fatty liver. So we are in front of an impending storm, and we also all need to know how to handle a patient with liver cirrhosis. So just a bit of the pharmacological or the chemical details, the liver cirrhosis and drug metabolism. So there are a lot of potential changes in the drug disposition or drug metabolism in cirrhosis. Cirrhosis has effects on drug absorption, distribution, bioavailability, and of course metabolism, because a lot of drugs are metabolized by the liver, especially by the cytochrome P450 system, as well as hepatic and renal clearance mechanisms. Because cirrhosis, remember, it is not it just does not involve the liver alone. It involves other liver organ systems, especially the kidneys, and it has a deleterious effect on the kidneys, which would affect renal clearance as well. So all these would result in pharmacodynamic consequences which affect the drug distribution or the drug metabolism in cirrhosis. Now, the simplest things are the absorption of oral agents may be altered or impaired by increased permeability in the presence of mucosal inflammation and edema in the gut, or due to delays in gastric emptying, or due to delays in gut motility. And of course, in patients with ascites and edema, there can be an effect on the volume of distribution, especially in hydrophilic drugs, because those drugs can be redistributed in the ascitic fluid as well. So this, for example, this is a picture of on the left. You see a picture of a normal stomach compared to a stomach with severe portal gastropathy, which is like there is a gastric mucosal edema, which will affect the drug absorption very significantly. So, elaborating further on that, there are several reasons why liver cirrhosis would affect the drug disposition. For example, patients with systemic shunts, it could be it could be therapeutic like TIPS, or it could be physiological or pathological shunts in advanced cirrhosis, which affects the drugs which have a significant first pass metabolism. So for drugs like beta blockers, which have a significant first pass metabolism, there is when the shunts are present, they are exposed directly into the circulation, and which increases the bioavailability. And of course, there's impaired renal excretion, as we discussed. There's portal gastropathy that affects altered drug absorption, reduced hepatic blood flow, which leads to higher bioavailability or serum levels. And hypoalbuminemia is another important factor when you think about drugs that have significant protein binding, which leads to increased serum concentration of the free drug. And of course, in the presence of ascites, you can have changes in the volume of distribution, and reduced cytochrome activity or reduced metabolism could lead to it could either lead to buildup of toxic metabolites, or it could lead to changes in the drug pharmacokinetics. For example, let's take a commonly used drug in cirrhosis like a loop diuretic, like furosemide or torsemide, in patients with ascites. So in these patients, these drugs have reduced elimination rates through both renal and non-renal routes. And the volume of distribution and the half-life is about twice normal, right? So they redistributed more and last longer in the body. But its natriuretic potency, or the ability to excrete sodium and hence water, is markedly reduced, because the loop diuretics, the delivery of the drug to the renal site of action into the renal the loop of Henle, is decreased because of the changes in the renal hemodynamics. So as you can see, there are a lot of potential effects in the drug metabolism and distribution due to the cirrhosis, which means that it's very difficult to predict what the final outcomes will be, what the dosage requirements will be, what the dosage adjustments will be, because this is multifactorial. So because of that, both these drug authorities like the Food and Drug Administration in the USA and the European Medicines Agency have proposed that you need to evaluate the pharmacokinetics and the dosing adjustments for most drugs in patients with hepatic impairment. So this is sort of a new, relatively new thing, not exactly new. And they recommend, for example, the FDA recommends hepatic impairment studies if there is hepatic metabolism or hepatic drug excretion, which accounts to more than 20% of the absorbed drug, or if the drug has a narrow therapeutic range. But practically, this is very difficult because there are different grades and different levels of liver impairment, and to test each drug and its pharmacokinetics and the pharmacodynamics at these different liver function levels is going to be extremely practically difficult. So because of that, this is not widely, universally practiced. So the problem we have is that in contrast to dose adjustment in renal failure, because we all know that in renal failure, your dosage adjustments are done mainly by the GFR or the estimated GFR. But in liver failure or in liver cirrhosis or liver impairment, there is no single broadly accepted method for dose adjustment, because no single value or no single investigation will give you a sort of a clear picture or a sort of a continuous assessment of what the liver function is going to be like. And as I said, like, for example, drugs with a normally high first pass rate extraction by the liver will have higher bioavailability and will require dose reductions. But of course, in order to sort of rationalize this, in order to sort of rationalize our recommendations on dosage adjustments, most recommendations are based on the Childs-Pugh stage, which is a method of grading liver disease, grading the severity of liver disease. It's one of the oldest methods, and it's one that is mostly used. It's widely used today. So as most of you already know, this Childs-Pugh scoring system has mainly 5 components, 2 clinical components and 3 biochemical components: encephalopathy, ascites, bilirubin levels, albumin levels, and the PT or the INR. So according to these, we give a score for each of these variables, and according to that, according to the total score, we divide the patients into Childs A, Childs B, and Childs C. So the final sort of the broad objective of this is to identify patients who have relatively normal liver functions compared to patients who have significant or serious liver dysfunction. So in order to categorize patients or stratify patients according to that. So this is a picture that we as hepatologists use very frequently. It was derived from a sort of a meta-analysis done in 2006, which compares the survival of patients with compensated cirrhosis and compared to decompensated cirrhosis. So this concept is extremely important because compensated cirrhosis, patients with compensated cirrhosis are generally, they have a good survival potential, and their liver functions are almost normal, near normal. And these are the patients who would be able to tolerate a drug which is sort of metabolized by the liver more readily. And these are the patients who are less likely to require dosage adjustments in these drugs. Whereas when you take decompensated cirrhosis, they have biochemical and clinical evidence of liver dysfunction. So those patients will require some sort of dosage adjustments, and in most drugs, you have to be careful in patients with extreme liver dysfunction or the stage 4 decompensated cirrhosis. But of course, Now this concept of compensated cirrhosis and decompensated cirrhosis is being replaced by the concept of compensated advanced chronic liver disease and decompensated advanced chronic liver disease, which is a term which is thought to be more practically useful, because cirrhosis, as you know, is a histological diagnosis. It's not a biochemical, it's not a imaging based or biochemical diagnosis. So technically, it is something that requires a histology to diagnose. Whereas when you take the term advanced chronic liver disease, we use non-invasive methods like biochemical tests and these liver panels, as well as things like liver elastography, to define this advanced chronic liver disease and portal hypertension and things like that. So this understanding and the definitions are changing. So that's also something that we need to be aware of. So a general rule of thumb for drugs metabolized in the liver. So generally, historically, what we used to say was that a child is cirrhotic with no varices, expected to live for 15 to 20 years, good survival, and they should normally tolerate drugs like a normal healthy individual. Whereas, and compared to the child C cirrhotic is someone who is with obvious liver decompensation, multiple complications, and a limited lifespan. So we are thinking about only essential drugs, and you have to use those drugs with extreme caution. And if the patient is being prepared for a transplant, then we need to be more cautious, I would say, in order to prevent any complications that would interfere with the surgery. Whereas you take the child's B cirrhotic, that is more of a gray area. It's somewhere between A and C, but then you need to define some sort of a method to achieve a dose reduction or to define a proper dose. However, when you take this Child's P scoring, there are limitations to it when you are using that alone as a system for a drug dosage. The first thing is it's a subjective scoring, especially for the clinical parameters, the encephalopathy and the ascites, because there are some for example, there could be comorbidities like heart failure or renal failure, which might affect things like ascites. So we are not sort of considering those or calculating those into the final outcome. And of course, more importantly, we do not account for renal function in Child's P scoring. So in a patient with renal impairment or chronic kidney disease or hepatorenal syndrome, for any reason, if the patient is having renal impairment, that would have a very significant effect on the drug metabolism and the drug distribution. And of course, it does not distinguish between different causes of liver disease. For example, we know that in cholestatic liver diseases, things like estrogen containing drugs can have a deleterious effect. So those are important factors. And of course, drugs that are sort of in biliary obstruction or cholestasis, drugs that are sort of secreted hepatically into the biliary system, the levels would go up. For example, tacrolimus. So, and of course, the correlation of the Child's P scoring system with the liver metabolic capacity or the actual liver, the capacity of the liver is not well established, obviously, because it's very difficult to define. And of course, even if you take patients who have the same Child's P score, there are multiple inter-individual variations. So it's very difficult to sort of generalize it to all patients with a similar score. So because of that, this is an extremely gray area, and you would not find any very solid sort of guidelines as to how to dose a drug or how to change the drug dosage according to the liver function. So because of that, we usually go with the recommendations found in things like the BNF or other formularies. Now, when we talk about drugs and the liver, especially in patients with liver impairment, there are two major components. One thing is the drugs that will cause liver injury on its own, or drug-induced liver injury. And also there is another factor in patients who have already liver impairment or liver cirrhosis. There are drugs that can cause decompensation of liver cirrhosis. Of course, drug-induced liver injury in itself is a very broad topic, And so to enter that topic, I have chosen a quote by Sir William Osler, who said that the desire to take medicine is perhaps the greatest feature which distinguishes man from animals. So he was, of course, you know that William Osler was considered the father of modern medicine, but he was very skeptical when it came to prescribing drugs. And he also went on to say that one of the first duties of the physician is to educate the masses not to take medicines. So it's more important to tell people when not to take medicines than to tell the people when to take medicines. So drug-induced liver injury is again one of the examples of drugs having a unintended or unexpected sort of detrimental effects. So just very briefly, there are several types of drug-induced liver injury. There are drugs that can cause direct hepatotoxicity, which is related to usually dose related. For example, high doses of paracetamol toxicity, or high doses of amiodarone, methotrexate, or chemotherapy. Those things, it's a dose dependent reaction, which is very which happens very quickly as a sort of a direct effect of the drug. And then compared to that or contrasted to that, there is the idiosyncratic hepatotoxicity, which is very difficult to predict. It's not as common as direct hepatotoxicity, and the onset is very variable. So it can take days to years. Sometimes you can be on the drug for years and years, and suddenly you get this hepatotoxicity. So it's not directly dose related, but I mean sometimes it can be dose related as well. For example, things like coamoxiclav or amoxicillin clavulinate and certain antibiotics and minocycline, fluoroquinolones. These are all examples of idiosyncratic hepatotoxicity. And of course, the third category is indirect hepatotoxicity, which is hepatotoxicity due to an indirect mechanism of the drug, which is usually a delayed thing. For example, glucocorticoids causing a fatty liver and liver fibrosis and things like that. And of course, these new biologics causing indirect hepatotoxicity, either by the sort of a direct or side effect of the drug or by a immune mediated system. So these are the three main categories of hepatotoxicity in the drug in drugs. And of course, there are different phenotypes or different ways that drugs can present as the drug-induced liver injury can present. For example, the most catastrophic one would be liver cell necrosis, which you get with paracetamol, high dose aspirin, and sometimes with MDMA, ecstasy. And the other phenotypes are things like acute hepatitis, which is characterized by sort of the relative elevation of the transaminases. For example, with non-steroidal anti-inflammatory drugs and with isoniazid. And of course, cholestatic hepatitis, which means that there is a proportionate elevation of bilirubin and alkaline phosphatase in relation to transaminases in a patient without any obstruction. So that is cholestatic hepatitis. The best known example is amoxicillin clavulinate. And of course, there are drugs that can cause steatosis, like glucocorticoids and tamoxifen. And there are drugs that can cause chronic hepatitis, like diclofenac, nitrofurantoin, minocycline. So chronic hepatitis in these patients could be something called drug-induced autoimmune-like hepatitis, where even the autoimmune markers might be positive and the patients would sometimes respond to steroids. And that would be an indication for the use of steroids as in the treatment. And of course, very sort of unusual ones like nodular regenerative hyperplasia, which is well known for thiopurine, which is hardly used now. But azathioprine is a well-known cause of nodular regenerative hyperplasia, where there is nodular regeneration of hepatocytes without cirrhosis, but which can lead to non-cirrhotic portal hypertension because of the nodules. So you may ask me how you would know how to which drugs cause what liver toxicity, and how to memorize all this and how to sort of analyze all this. So the simple answer is you don't need to memorize any of this, but of course you need to know the common drugs. And this is the sort of the liver tox database If you just search on Google, you will find it, and that is the well established, that is the universally used database on drugs and their liver side effects. So you can go through it. It's very extensive. You can use, I mean, almost all the drugs under the sun you can find on this database. So this is something that you can use and sort of find out what the liver side effects of the drugs are very quickly. And of course, then comes the question about drug-induced liver injury in cirrhosis. So that is one of the reasons why we are afraid of prescribing drugs to patients with cirrhosis. We are afraid that the drug will hit the liver when the liver is already down. The liver is already damaged, and we are worried that the drug will cause more damage, like Brock Lesnar is doing to this other his competitor in this fight. So the short answer is drug-induced liver injury does not happen more frequently in cirrhosis in almost all the cases, but there are exceptions. So idiosyncratic reactions do not occur more frequently in patients with liver disease. However, if a patient with liver disease gets hepatotoxicity, one thing is it would be difficult to detect that hepatotoxicity, especially if the patient is decompensated, right? So if the patient has high bilirubin and low albumin or high transaminases or something due to the liver injury itself, then that would mask the potential drug-induced hepatotoxicity. So that is something that we need to be extremely cautious of when prescribing for decompensated cirrhosis, patients with decompensated liver disease. And of course, the consequences, if you get a drug-induced liver injury in a patient with already impaired hepatic function, would be much more serious. And then they can go into liver failure or acute on chronic liver failure, which would have a significant effect on the mortality and the morbidity. But there are certain drugs that are thought to have an increased risk of hepatotoxicity when used in patients with liver disease. And there is adequate evidence for some of these drugs. For example, antituberculous drugs like isoniazid, pyrazinamide, rifampicin. You have to be extremely careful in decompensated liver disease patients. Another important category is highly active antiretroviral therapy. That again, those antivirals, there is an increased risk of hepatotoxicity in patients with already pre-existing liver damage. And of course, things like methotrexate and valproate, you have to be very careful. Those are important examples where you need to be careful in patients with pre-existing cirrhosis. Now, how do we manage a drug-induced liver injury? I mean, you can apply this to both patients with or without liver cirrhosis. You have to take a good drug history, including herbal medicines. We will touch on this a little later. And of course, exclude other possible causes of hepatitis like alcohol and viruses, and stop the offending drug, stop the suspected drug. And of course, the treatment is mainly supportive. Supportive to treat the patient, hoping that the patient will get better. But if you suspect an autoimmune or drug-induced autoimmune hepatitis, where some of the autoimmune markers are positive, then you can consider steroids. And typically, this sort of using steroids for this sort of a situation would be more short-term compared to a typical autoimmune hepatitis, and it would you can safely withdraw the steroids without any relapses if it's a pure drug-induced hepatitis. And of course, management of acute liver failure, because a certain proportion will go into acute liver failure, and prepare for liver transplantation if there is a acute liver failure. So this is a girl who had an acute liver failure for induced by antituberculous medication, who had a liver transplant at Ragama a couple of years ago, and now she's healthy and living a normal life. So how do you prevent drug-induced liver injury? Use all drugs only when absolutely necessary, especially in patients with pre-existing liver disease. And you have to have a high index of suspicion, because sometimes the patient's biochemistry, liver biochemistry may already be altered. And also, there are certain tests you can do before starting the drug, which might help to find out whether it's suitable for the patient or not. For example, something like a liver stiffness measurement in a patient with suspected non-alcoholic steatohepatitis before starting things like tamoxifen or more importantly, methotrexate. So if the patient already has significant fibrosis, we would avoid drugs like methotrexate. And of course, you have to monitor the patients frequently for symptoms and signs of liver disease, as well as monitor the patient biochemically very frequently for symptoms for any alteration of the liver functions. Another important upcoming topic area is herb-induced liver injury or HILI, because now there are all over the world, especially in the developed world, there is a rising use of alternative medicines for medicinal purposes or weight loss purposes or as food supplements. There is this whole back to nature movement which would which has increased the use of these herb products. And with this, there is a rising incidence of liver injury from the use of these medications. And it's very difficult to sort of pin down or identify which component or which herb causes these problems or which chemical causes these problems, because most of these preparations are cocktail or combination of different compounds. So it's very difficult to isolate them. And of course, because the purification process or the preparation process of these drugs or these compounds or these medicines may not be sort of uniform, and there may be contaminants like heavy metals which may contribute to liver damage. So the drug itself may not be responsible. And of course, it's very difficult sometimes to get the history because the patient may not consider it as a medication and may not divulge it. For example, I recently saw a patient who had cholestatic hepatitis, which we could not sort of find a cause for despite extensive investigation. And later on further questioning, she said that she was using a weight loss green tea for about 3 months prior to this presentation. But of course, it's very difficult to establish causality there and to sort of implicate green tea as the only sort of we can only postulate that it's the cause. But of course, these alternative medicines or herbal medicines are now being widely used, and it's something that's been practiced for a long time, maybe much longer before this Western medicine was introduced to countries like ours. So of course there is a therapeutic benefit to it, but of course there has to be some sort of a regulation of this, because there are lots of different formulations, lots of different manufacturers, so there is no uniformity or quality control. So, for example, in the United States, the herbal or a dietary supplement was the 4th leading cause of drug-induced liver injury or herb-induced liver injury or whatever, requiring liver transplantation. So it's a significant burden there. So alternative medicines are not totally safe. So we have to encourage more research on the subject, and we have to encourage regulation of these medications and reporting of adverse events. And of course, there has to be greater collaboration between the different systems of medicines to identify and to make the use of these herbal medicines or alternative medicines safer. Right. So that is just about the herb-induced liver injury. So I'm now just going to touch on some brief classes of drugs or some brief sort of important classes that we need to know about when prescribing for a patient with liver injury. So one of the most important factors in cirrhosis is the pain management. Okay? And paracetamol, when we think about paracetamol is well known to be toxic to the liver when taken in overdose. But the bottom line is, if taken appropriately, paracetamol is probably the safest analgesic in a patient with cirrhosis. So this is because when you take the appropriate medication, appropriate dose, if you take it, like for example, if you look at all the literature, if you take a dose, paracetamol dose of about less than 2.5 grams a day, there has been no reported cases of liver injury or alteration of liver enzymes. Whereas compared to there was one trial or one study where they gave healthy volunteers 4 grams of paracetamol per day continuously for 2 weeks, and found that a significant amount of them developed asymptomatic alteration of liver functions. But 2.5 grams is thought to be the cutoff where you don't get any liver issues at all. So that's why we recommend about 2 grams, less than 2 grams of paracetamol per day for patients with cirrhosis. But funnily enough, we know that this compound called NAPQI, NAPQI, is the one that causes the toxic damage to the liver in paracetamol overdose. And you have glutathione, which sort of it neutralizes the NAPQI. But of course, in patients with cirrhosis, this production of NAPQI might actually be less because the cytochrome P activity, the responsible cytochrome enzyme, might be less active or less active in patients with liver cirrhosis. So, but of course, that does not mean that we recommend the normal dose. We recommend 2 grams per day as the recommended dose. What about non-steroidal anti-inflammatory drugs? This is another important area that we need to be aware of. There are several reasons why you should avoid NSAIDs in patients with cirrhosis. The most important of that is the renal effect, because we know that it has a prostaglandin inhibition and reduces the renal perfusion. So it can precipitate acute renal failure, especially in patients with pre-existing kidney disease or patients with very advanced cirrhosis with hepatorenal syndrome. And of course, it can precipitate GI bleeding due to direct irritation. And it promotes sodium and water retention, worsening edema, and it increases the risk of platelet dysfunction. So there are several ways by which the non-steroidal anti-inflammatory drugs can affect or damage patients with pre-existing cirrhosis. So the bottom line is you should avoid it in patients with cirrhosis unless absolutely necessary for very short periods. But topical formulations may be considered. So if you can get away with a topical formulation of NSAID, as long as you keep the dosing to a normal sort of recommended dose, it should be all right. Another important sort of interesting area is the COX-2 inhibitors, which in some animal studies they were shown to reduce the progression of liver disease and fibrosis and things like that. But there is very limited evidence in cirrhosis, and as of now, we don't have evidence to recommend them compared to the normal NSAIDs, or to say that they are safe in cirrhosis. Gabapentin and pregabalin are two important sort of analgesics which are not metabolized by the liver. So they are both renally excreted. So if the patient has renal dysfunction, we need to adjust the dose. But it is something that we can consider as first-line non-opioid therapy, especially for neuropathic pain. So gabapentin and pregabalin, for example, we can start gabapentin at a dose of around 50 milligrams twice a day, and then gradually titrate upwards. Provided the renal function is normal, the patient should be able to tolerate it. Of course, the use of opioids are actually quite complicated, but the bottom line is most opioids need to undergo some sort of metabolism to its active form. So most of them are affected in liver impairment. So, for example, things like codeine, it is hardly effective. It's not something that there is very little effect. So it is not recommended to be used in patients with liver cirrhosis. Whereas something like tramadol would be it would be safer, especially because it has minimum sedating effects, because other opioids might cause a sort of worsen hepatic encephalopathy, or because due to their sedative effects. So tramadol is another, but the important thing about tramadol is that it can cause serotonin syndrome in patients with who are already taking SSRIs or tricyclic antidepressants, and of course it can reduce the seizure threshold. So it should be avoided in patients with seizure history. And then another very interesting and important thing we need to know is that it's about the use of acid suppressive therapy. This is for both proton pump inhibitors and for H2 receptor blockers. Now, acid suppressive therapy, especially PPIs, are known to be have been shown to be a potential risk factor for SBP, C. diff, and other infections in patients with cirrhosis. So how this happens is a little, it's probably a little complicated, but it's probably related to the alteration of gastric impairment, the gastric environment, sorry, and that causing the bacterial overgrowth or the dysbiosis inside the intestine. So we know that when you talk about pathophysiology of most of the cirrhotic complications, we talk about gut bacterial translocation, where you have damage to the gut bacterial, the gut the blood gut barrier, and that causes translocation of the bacteria into the blood, and that bacteria would that septicemia or that bacteremia would induce a cascade of inflammatory responses that leads to all these complications. So simply put, this is probably the reason why there is increased risk of SBP and other complications in patients with the use of acid suppressive therapy. The risk is more compared to H2 receptor blockers. The risk is more with PPIs. So acid suppressive therapy should only be used when clinically indicated, especially in patients who already have ascites, because those are the patients at risk for SBP. So only when clinically indicated and for the shortest duration possible. So they should not be indiscriminately on acid suppressive therapy for long periods. And of course, when you talk about anesthesia and sedation, propofol is probably the most preferred sedation option, especially for patients who are undergoing endoscopy, decompensated liver disease or cirrhosis patients, because of its short half-life and rapid action, because it does not cause prolonged drowsiness and things like that compared to benzodiazepines. Because benzodiazepines are well known to precipitate or worsen hepatic encephalopathy and delay recovery. So propofol is preferred. And of course, another important class or super drug that we use in a lot of our day-to-day practice are the statins. Now, the relationship of statins to liver is very complicated. So initially, when couple of decades ago, statins were not they were thought to be detrimental, or they were thought to be a risk in patients with cirrhosis. This was mainly because of the risk of drug-induced liver injury. So statins were thought to be potentially hepatotoxic, and because of that, it was recommended to universally avoid statins in patients with cirrhosis. But when you actually go into the details or the numbers of statin-related liver injury, the most common one is a mild, early, asymptomatic, and most importantly, self-limiting elevation of AST and ALT in about 3% of patients. So this happens usually in the first 3 months of statin therapy, and it's self-limiting. So even if you continue the statin for during this period, the AST ALT would gradually come back to normal. Significant drug-induced liver injury has been reported in one in every 3,700 to 11,000. So it's relatively rare. So it is rare. And cirrhotic patients are not at increased risk of drug-induced liver injury. So as I told earlier, in most cases, cirrhotic patients are not at risk of higher risk of drug-induced liver injury due to statins. But risk of muscle toxicity may be higher in advanced cirrhosis, especially when you are using these lipophilic statins like atorvastatin or simvastatin, which are the ones we use in liver disease. But of course, we know that statins have what we call pleiotropic effects, which are anti-inflammatory, anti-angiogenic, anti-fibrotic properties. So you know that statins are HMG CoA reductase inhibitors, but they are supposed to have this multitude of other an array of different properties which have a beneficial effect on a lot of different systems. So it's now there are a lot of evidence coming out that these effects may be beneficial to prevent progression of liver diseases. For example, it may reduce the progression of portal hypertension or reduce pre-existing portal hypertension, and also reduce the risk of hepatocellular carcinoma in patients with chronic liver disease. So if you look at this, I'm sorry about the crowded picture, but if you look at the different areas where where statins are supposed to postulated to be useful. One thing is it is now said that the progression of NASH or any form of liver disease into cirrhosis or the fibrosis part might be inhibited or delayed by statins, as well as the progression from the onset of cirrhosis onto the first decompensation may be delayed by statins, as well as the acute or chronic liver failure and development of hepatocellular carcinoma, or even the overall mortality might be will be sort of potentially there is a potential benefit by the usage of statins. So you may see in the future that statins will be recommended. Cirrhosis might actually become an indication for statins, whereas now it's just statin use is generally in the guidelines. It's recommended just based on standard sort of indications, even in patients with cirrhosis. But in the future, it might come into statins might come into the usual drug cocktail we use for any patients with cirrhosis. And another important area is oral hypoglycemic agents. Metformin again is a time-tested drug. I mean, it's been used for a long time, and it was again a drug that was sort of avoided in patients with cirrhosis. But now the evidence says that there is no increased risk of drug-induced liver injury, and lactic acidosis is extremely rare in patients, especially with patients with Child's A and Child's B cirrhosis. But of course, you should be cautious in patients with Child's QC, and especially with patients with ascites and renal impairment. So that is an area where you need to be cautious. I suppose that's an area where you need to be cautious with any drug. When you talk about sulfonylureas, short-acting ones are preferred, and you should avoid in severe liver impairment. Another sort of relatively new now, I would say that it's more of an established therapy, are incretin-based therapies, the DPP-4 inhibitors, the sitagliptins, and of course the GLP-1 agonists, like the glutides, liraglutide, the semaglutide, things like that. These drugs are barely metabolized in the liver and are excreted unchanged by the kidney. So they have a low liver toxicity, and usually they are well tolerated. But again, if there is severe liver impairment, you need to be a little cautious. So this was like it's very difficult to cover all the drugs and all the sort of categories and all the cautions we need to exercise. But the bottom line is most drugs can be used safely in cirrhosis, but you need to be very selective in the patients and be selective in which patients with cirrhosis you use them on. And the relation of drug dosage, or the definition of how to establish a drug dosage with liver impairment is poorly defined. And drug-induced liver injury is not more common in cirrhotic patients, but the effects can be detrimental. And there is a potential for modification of the natural history of cirrhosis with some drugs. So that is basically all I wanted to cover at this point. Thank you so much. And if you have any questions, I would be happy to take them.
Thank you, Udita. Thank you for that comprehensive presentation, and you did cover almost all the commonly used drugs in day-to-day practice. Thank you for that. I had two questions actually. While inviting our audience to post more questions in the chat box, may I ask you, you mentioned about nodular regenerative hyperplasia following azathioprine. May I ask you, if a patient developed NRH following azathioprine, would you say it's contraindicated for the rest of the life, or would you consider restarting it at some point?
Well, I would, the experience I have was when I was practicing in the UK, and there they would I have never seen them re-challenging or restarting azathioprine in a patient who has already had nodular regenerative hyperplasia. They usually switch to a different agent.
All right, thank you. We are getting few questions in the chat box. While we are getting more questions, may I ask another one? You did mention about most commonly used drug groups. May I ask you about loop diuretics? What is your opinion on prescribing furosemide and loop diuretics in a patient with advanced chronic liver cell disease?
Okay, thank you. So that's a very interesting and a broad question, Meranti. So because loop diuretics, on one hand, we know that we use them for patients with ascites, with decompensated cirrhosis. But at the same time, patients with ascites are more prone to get renal impairment, are more prone to get hyponatremia. So there are a lot of things that we need to consider before starting a loop diuretic. But the main thing is, I think the usage of loop diuretics, if you use it with a potassium sparing diuretics at the right dosage, sort of this ratio, where you use, for example, if you're using spironolactone, you would use 100 milligrams of spironolactone for 40 milligrams of furosemide. So if you use it at that correct dose, especially for patients with hyponatremia, because we know that the hyponatremia is more due to dilution rather than to deficiency in sodium, that would sort of be that can be used with caution rather than to avoid completely avoiding it. And the other thing is, especially when it comes to renal impairment, there are, you have to approach it in multiple different ways. For example, in a patient with 10 ascites and renal impairment, I would think about doing a therapeutic paracentesis before starting on diuretics, because the paracentesis itself may cause may improve the renal functions and the blood flow to the liver. So like that, I would approach it in sort of it's a very complex question, but I would approach it in a case-based or a patient-based manner.
Yeah, thank you for that. Let's get on to the questions in our chat box. There's one asking about paracetamol. If a patient is on paracetamol recommended daily dose, if the patient is happen to get increase in transaminases, is it safe to continue paracetamol?
So, as I said earlier, now there was this one interesting study where they gave paracetamol programs daily to patients without any liver issues for about 2 weeks, and a large proportion, significant proportion of them developed elevation of transaminases. So again, I would now, when you consider taking paracetamol, it would all depend on the indication and the duration for the use of paracetamol. But the development of altered liver functions, let's say, especially in a patient with already damaged liver or with cirrhosis, I would say would at least require you to take a holiday or give a break and stop the drug, because I mean, I can't think of any indication where you need to take paracetamol every day for 3-4 months, right? So maybe use an alternative, or maybe sort of give a drug holiday. And I would say that you have to be extremely cautious when thinking about this transaminases. Of course, there are these arbitrary cutoffs, and in most drugs, we would wait until the transaminases, or especially the ALT, is more than 3 times upper limit of normal before calling it a significant elevation. So we need to sort of look into that, as well as factor in other factors that might lead to other sort of that might lead to elevation in the transaminases.
Yeah, thank you, Peter. I just wanted to ask another question related to that question. In a patient with cirrhosis, there might not be significant elevation of transaminases if there are no much hepatocytes left.
Yes.
What is your opinion on that?
Absolutely true. So in a patient with especially decompensated cirrhosis, transaminases are not something to go by for anything. I mean, you can't decide whether the liver is getting better or worse depending on the transaminases. You're absolutely correct, Meranti. So it's not useful in a patient with a decompensated or burnt out or very advanced cirrhosis. You should go with the liver function test, things like INR, bilirubin, and albumin, rather than going just with transaminases.
Absolutely.
Yes.
Another question. I know you did mention about antibiotics, but there's a question on antibiotics. Can you give a few tips on use of antibiotics in chronic liver cell disease patients?
Okay, so the problem here is, like, in most cases, these antibiotics we have not extensively investigated in patients with, for example, patients with child A compared to child C. So there's very limited evidence. but there are certain antibiotics that that are known to cause drug-induced liver injury. For example, co-amoxicillin. So in general, we would sort of try to avoid that sort of a drug in a patient who already has decompensated liver disease unless there is a strong indication. And there are certain antibiotics that have been sort of time tested and that sort of have been used in trials, and those are the things that have found their way into guidelines. So I would say stick to those antibiotics, especially when you're complications of cirrhosis. For example, in a patient with spontaneous bacterial peritonitis, you should stick to like third generation cephalosporin because that's like the one that's been used. And of course, there are other drugs that are coming into the recommendations, as well as for prophylaxis of BP in patients who have recurrent episodes or patient with high risk. You can use norfloxacin because those are the things that are recommended in the guidelines, Cipro, norfloxacin, things like that, and drugs like rifaximin. So I mean, there are certain drugs which especially the antibiotics, old antibiotics like tetracyclines and certain macrolides and antifungus like fluconazole, that would where you need to reduce the dosage of the drug in patients with liver impairment because the bioavailability becomes higher. So because of that, when using a drug that is not commonly used, when you have to prescribe something, it's always better to go into details and sort of refer formulary because you can't remember everything, unfortunately.
Meranti,
Yes,
can
sir.
you hear
Yes.
me? Yeah, can we ask questions also?
Yes, sir. Yes, please.
Yeah. Udita, can you hear me?
Yes, sir. Yes, sir.
Yeah. Thank you for the talk. I know that you were pressed for time. It would have been nice to include the anti-TB drugs also, because that's a very common drug that is causing a lot of problems in patients with TB, because there is, it's common to have TB in cirrhotic patients, not uncommon to have. One thing that I want to just comment, that people are very scared to prescribe statin in the presence of chronic liver disease, let alone cirrhosis. They are scared to prescribe statins even in the earlier stages, like in NAFLD and NASH. So that's a very important point that you highlighted, that statins are quite safe in compensated cirrhosis, and it might prevent further decompensation and even the development of clinically significant portal hypertension and even the development of HCC. So statins are probably coming to the guidelines as a agent that can be primarily prescribed for compensated cirrhosis. And if there is a compelling indication, please do prescribe statins in cirrhotic patients because it's helpful. Thanks.
Thank you, sir. Yeah, agree completely. Yes.
Thank you, sir. Thank you for that comment. We have another question in the chat box. Dr. Vidya is asking, when a patient is on a methotrexate and found to have cirrhosis, how will you proceed? I would, so I can't, so because like I can't think of any reason why methotrexate, I mean, unless in very rare cases, why the methotrexate is the only option at that point. Because in a patient with significant liver fibrosis who's on methotrexate, I would try to avoid it as much as possible. But if there is no viable alternative, then I would be extremely cautious when proceeding with it. And there would have to be regular monitoring, especially in patients who are not like who have fibrosis, some degree of fibrosis, maybe with a fibroscan, maybe periodic monitoring to make sure it does not progress. But I mean, as it has been recently shown, methotrexate tends to worsen pre-existing fibrosis rather than to cause fibrosis on its own. So I would personally try to avoid methotrexate in patients with any degree of cirrhosis. Yeah. The next question is, what is the rationale behind discontinuing diuretics in a patient with hepatic encephalopathy?
Okay, so that is a sort of a good question. So there are several ways why diuretics can affect your the encephalopathy, or can precipitate encephalopathy. One thing is in patients who do not have ascites, the patient is already on diuretics, then the patient might get dehydrated because of it, right? So that is one reason. Other thing is diuretics can cause electrolyte imbalances like hypokalemia or hyponatremia, or worsen already existing electrolyte imbalances, which might worsen the outcome or may worsen the severity of hepatic encephalopathy. So it is because of those reasons that we try to avoid diuretics in hepatic encephalopathy.
Thank you, Udita.